thank you so much for attending this session. So I'll get started. The purpose of the presentation is just to tell you about the Quality Improvement Project to help my rural diabetes patients be more controlled. And I hope that you will be able to discuss a strategy for medication adherence after we get through. So let me say, let's do a quick vocabulary lesson. You know, you can take the girl out of the education setting, but you can't take that out of the education out of the girl. So let's have a vocabulary lesson. So a boon is a thing that is helpful or beneficial. And so I found some humorous things. What are some things that are helpful or beneficial? A multifaceted kitchen tool, a bug sucker, which there in the upper right is that sucks bug venom out of your skin after you get a bug bite to prevent itching, I suppose. And then a doggy paw cleaner and massaging slippers. So those are some, a boon is something that is beneficial. A bane is a cause of great distress. So there's a story behind these pictures. And when your husband comes and says he has already paid for a new squirrel dog puppy, and he says, I'm going to take care of it, you know, he lies. And then the squirrel dog later eats your 3-year-old grandson's corn dog, and you know that you don't have any in your freezer, and the nearest Sonic is 15 miles away. That's a bane. And a bust is something that is worthless. And you can see these signs, which actually made me laugh out loud. Or diet water is worthless. Another definition of bust could be to come apart, which we in the South know that we have an alternative use for that, which I could say that I had a come apart when that dog ate my grandson's corn dog. But anyway, so I want us to think about these terms in relation to the project that I attempted with my rural diabetes patients. Were there benefits? Did they cause distress? Or was it just a worthless effort? So let me give you some background. Of course, Alabama is in the diabetes belt, as most of Appalachia. These are our latest rates, and you can see in the counties in which this project took place, Bibb County, which is just below, this is Jefferson County. I know there's probably a pointer, but Jefferson County is just east of Bibb County, and then Tuscaloosa County. For my UA friends, that's just northwest of Bibb County. And then Chilton County is southeast of Bibb County, and Perry County is southwest of Bibb County. And Perry is at the northern edge of the Black Belt in Alabama, where our worst health outcomes occur. And you can see there the difference in the rate. Perry County, I think, is third in the counties of the state of Alabama as far as diabetes rates. So the background of this project was that oral medications are a simple therapy. Most people can afford metformin. It's an inexpensive drug. But why are people taking their metformin or their medications? And as I really became immersed in my practice, I would think to myself, if only you would take your medication, you know, this would help you. What can I do to help my patients with their medication adherence? And I know then that communication is good for between a provider and a patient. And we have this explosion of technology. What if we can use technology in rural patients' settings to encourage medication adherence? It's not been well studied. The use of texting has been proved well. It's research suggests that it's useful in other settings, but it has not necessarily been studied well in rural settings. So in our clinics, I did a chart review. There were quite a few patients, 351, that were not able to achieve an A1C of less than 8% in this particular calendar year. There's low adherence to medication in 63% of rural diabetes patients, according to one study I read. And then it was exploring why patients don't take their medications. One of the things it said was that they ration their medications. They can't afford them, so they ration them, or they believe that, and that's a cost-related non-adherence, that's CRN, that's a term that we hear more frequently because they just can't afford it. They treat the symptoms. So maybe they take their medications when they see their blood sugar go high, and when it's under a better control, they stop taking it, thinking they don't need it. They also are afraid. I've heard of patients, and this was supported in this particular research study, that they're afraid of hypoglycemia. They're afraid if they take their medication, they're going to get hypoglycemic and they're going to go into a coma, and nobody's going to be there. And that's especially worse, I think, with people that live alone. And then there's that fatalism that a theme that I've heard in other sessions here, where people just think it's just meant to be. I have diabetes. This is my cross to bear. This is what I'm going to live with. And they think that there's no getting around that. And then they just forget. And I was astounded in this one survey that 30% of the patients in this survey reported that they had forgotten to take their medications the day before. So people just forget. So then that brings me to another reason for the texting. If, as according to the Pew Charitable Trust, 91% of rural residents own a cell phone, why can we not use that to remind them to take their medications? So as I set up the project, we asked the question, would texting make a difference in medication adherence? And our intent was to look not only at their pre and post A1C over a 12-week period, but we also wanted to look at medication refills. And then we also wanted to get some post-project qualitative information from the patients. Our conceptual framework was a little different than the typical nursing framework. BJ Fogg is the author of Tiny Habits, the small changes that change everything. And he has a behavioral model theory, Fogg behavioral model. And his theory was that there were 3 conditions needed for a behavior to occur: motivation, ability, and a trigger. And so the assumption for us was that the patient has the ability, they can afford an oral medication, and that was what our focus was going to be on, oral, easily accessible medications. That they want to get better, that was a basic premise also that we had to include in our framework. And then we hoped that our text was going to be a well-timed trigger to encourage them to take that medication. So this is our inclusion criteria. I will say a couple of things that we adjusted. We wanted an A1C greater than 9%, but from our patient participant pool, we really did not get enough to support greater than 9%. So we dropped it to 8%, which is still uncontrolled for most patients. We had wanted to look at oral diabetes medications only, which we really did, but we did have to include some patients that were on insulin. And I'll come back to that in a second. We also wanted to look at pharmacy data because in our EHR, we get information as to when the patients refill their medications. We can check their refills. So that's what we were gonna look at as well. The problem there, and I will go ahead and address that, is that when a patient is uninsured, we don't get that data. We get the data that we prescribe, that we send that, we e-scribe the medications to the pharmacy. But unless they have insurance reimbursement, we don't always, and actually very seldom, do we get confirmation back from the pharmacist that that medication was filled. So that really was off the table soon. We did not realize that was the case. And also at the time, there were a couple of mom and pop pharmacies that did not have that interaction with our EHR. So we really couldn't follow up on that. And also, as far as the diabetes, the oral diabetes medications, if a patient was put on insulin during the course of this project, we removed them because we didn't feel like that was going to be a fair observation outcome. So there were two of our original 34 participants. There were two that did go on insulin during the project that we took out of our final outcome. So the project was for 12 weeks. We were going to text them 3 times a week, twice a week with medication reminders, and once a week with a simple diabetes fact that was written on a 5th grade level. We wanted to make sure that our literacy was appropriate for all patients. And our outcomes were going to be measured by pre and post A1C. And then we wanted to do some qualitative information from our patient. And of course, medication refills, I've already explained why we did not get to go into that. And let me make a statement about the Remind 101 app. Are y'all familiar with Remind 101? Schools began to use that a lot in recent years. Remind 101 is a communication app that you can download to your phone. It is HIPAA compliant because you can enter a text and it goes, you have a database of your recipients, but it goes directly to the recipient without revealing other numbers within the system. So the problem here, and you will see in latter data, that it gave us an opportunity to look at some other things as well. But half of our participants accepted the invitation to the Remind 101 app, and half of them didn't. So immediately I thought, how are we going to do this and not lose our few participants? Because I had tried to enroll at least 100% participants and I didn't get enough to do that. And so how do I do this? So my project partner then took over the Remind 101 and she texted half of the patients with the Remind 101. I texted half of the patients one-on-one personally. So I had half, and I had the short message service, the regular texting that I texted one-on-one. So I sent out 17 texts every time I sent a text. And then my project partner did the Remind 101. Same message, just a little different delivery. All right. These were our texts, and we tried to really make them friendly and warm and pleasant and engaging. So this was sent, the medication reminders we sent on Monday and Friday. And then our diabetes facts, which were adapted from the American Diabetes Association, we changed the wording, of course, to do a 5th grade literacy level, which we checked against one of the online databases. We tried to give them information that could be useful in a very simple and easy to understand manner. And this was one of the screenshots of the text that I sent with the text exchange with a particular patient. They did have the opportunity to respond with a short response, like, did you take your medicine today? In the Remind 101 app, they could put yes or no or not yet or something really short. One of the and that became part of our data, and I will share that with you in just a few minutes. So this was how we recorded. The blue horizontal rows were the Remind 101 communication, and then the green were the SMS. And so each day that we sent a text, we recorded if there were any responses and exactly what wording we used and so forth. And so our outcomes were as posted there. The mean pre-A1C was 9.6 and post was 9.4. So while there was some improvement, there was not a statistically significant improvement. Our diabetes text, we sent out a total of 1,146. We had 230 patient responses. And as you can see, it seemed like their interest may have waned. We had 110 in the first 4 weeks, then we had 63, then we had 54 in the last 4 weeks. And I've already explained why we were not able to use the medication refills as a measure of medication adherence. And our changes in A1C ranged from an increase. I was thinking, how in the world can you increase your A1C when we're begging you to take your medication? But it happens. And so we had one patient whose A1C increased over 20%, but then we had one patient who had an excellent outcome and was real. I mean, I think their A1C came from 11 point something to between 7 and 8. That person made remarkable progress. And as we looked at our text data, I'll explain this. You can see the total number of texts that we sent for the weeks, and then the total number of patient responses are the shorter, darker green columns. And then you have the two lines there. The upper line are the number of responses from our Remind 101 app users, and the lower darker line is from our regular texting. So what we thought here was that, hey, even though the difference was not great, we had more responses from those users of Remind 101. Does that mean they're more engaged with technology than those who had regular text capability and were only communicating via regular text? So back to the Boon. So what lessons did we learn with this? Well, half of the patients who received text, over half, I'm sorry, I've already mentioned this, getting ahead of myself. So the ones who received the text through the Remind 101 app were possibly more tech savvy than the others. They were more comfortable using an app. But this is the real benefit. Over half of the participants experienced a decrease in A1C ranging from 1.1% to 38%. So texting may be useful for some patients. Let me do a disclaimer here. We have really significant no-show rates at our FQHC. So I was only able to get post data on 21 of the 29 patients who finished the project. So I need to let you know that as well. So we did not have complete data at the time, but the ones that we were able to get, because they had to come back within a certain length of time to have a follow-up A1C for us to count on. So the Bane, what causes us distress? And I pored over charts. I read charts and read charts. So one of the things that bothered me about this was that we providers often escalate care, we escalate dosage without really documenting that whether the patient is taking their medication. We do not ask that question. So when I went back and looked at the charts and compared those to the refill data, I found that we don't ask the question, are you taking your medication? Great if we have the refill history, but what about those sliding scale patients, uninsured patients who we don't know if they really are taking their medications or not? We don't ask the question. And also one thing that was very troubling and enlightening for me is that very few patients have documented clinic visits for diabetes education or nutrition education. That's something that's essential according to the ADA, American Diabetes Association. You know, they should have diabetes education when they're diagnosed, when their A1C becomes out of control, or annually. And you know, it should be part of their regular routine of care, and they don't get that. There is a significant amount of residual mistrust in rural healthcare settings. And honestly, I find that, I think, in greater amounts with my African-American patients. What has been done in their healthcare in the past is a travesty that we're still living with the consequences with. So we really need to be aware of how we approach our rural patients, be aware of where they're coming from. And I'll address some of that if I have time. I have more thoughts about that. So those are areas of distress that we need to be aware of as providers and clinicians in caring for this. And the worthless part, and every experience is a learning experience, but what I learned also is that when I did the initial chart reviews and the search through our EHR for the number of patients, I got a tremendous number of patients. I thought, my gosh, we have so many who are out of control. What I did not realize was that for every one of us providers at Woodstock, every time I looked for a diabetes patient whose A1C was greater than 9, I got every patient came through with every provider. So there were 4 of us at the time. There was me and another nurse practitioner, and then 2 physicians. And so that person, that same patient, would come through 4 times because they were all our patients. I had this huge number of patients, and I thought, man, that's a great participant pool. And then when it came down to it, it really was not. So I was going to do this at my faculty practice site, but I had to expand it to the other rural clinics in Bibb County and in the state of Alabama, not only Bibb County, but in Perry and Chilton County as well. Remind 101 limits their text to 140 characters. So I learned very quickly how to implement plain language on these, because you couldn't do long text. So that was, I felt like sometimes our message got a little bit blurred because we had to make the text so brief. And then again, our participants were on multiple therapies. So it was difficult sometimes to really focus just on the oral medications. You know, those patients who really could benefit from inexpensive metformin if they would just take it. It's just difficult when there are all these confounding factors. But the implication was that we do know that technology can be used to relieve the burden of chronic disease. That texting was well received by half of the participants. And because of COVID, we didn't get to do our post surveys, but one of these patients came in and I saw her a couple of months, well, no. It was probably a year later because it was after the worst of COVID, because COVID really happened pretty much after this cessation of this project. But I asked her, I said, do you remember getting the text? And she said, yeah. And she was one of the ones whose A1C had improved. And I said, do you remember she reminds me of Aunt Clara on Bewitched. Do you remember that show? And I said, well, what did you think about that? And she said, you know, I thought if y'all cared enough about me to send those texts, I ought to care about myself. And I thought that was so sweet. And that's the kind of benefit I wanted for these patients. And at least one patient found the 5th grade level literacy too simplistic. She said, I want to know more. And I started thinking, what if we do this serially? What if we do a serial, 3 months of simple facts, then advance the content so that they do know more about their disease and how to treat it and the lifestyle management that's required. And so I feel like we've learned a lot, and we could probably use technology more. I'm not sure that it's going to be possible in this particular patient population at this particular time. I think we need to learn more. There's actually been a randomized control trial since this, and I think it was in South Africa, who had the same type of outcome. There were non-significant findings in their findings as well. So we have a lot to learn, but we meet our patients where they are. They become part of our heart, and we're always thinking of ways to improve their health care. So thank you so much. These are my resources. And does anyone have any questions? Yes.
You made a comment that 50% of your participants liked the message. Did you talk to any of the 50% who didn't about why they didn't like it?
I did not. And that's one of the things that we really wanted to go back and find out what their post-project perceptions were of that communication. Yeah, so I didn't, but that would be good information to know. Yeah.